So I'll start by introducing our first speaker, Dr. Fahad Derakoni Hassani. He is graduate from Residency Training Program in Neurosurgery, Department of Neurosurgery, Mohammed V University and WFNS Rabat Reference Center, Morocco in November 2014. He has published 20 papers and wrote one chapter. And he has special interest in spine surgery, minimal invasive spine surgery, skull-based surgery, stereotactic and functional neurosurgery, glioma surgery, education research and innovation. He is a university diplomate from Mohammed V University of Rabat in University Diploma Medical Education and Pedagogy and University Diploma on Epidemiology and Statistics, and he has diploma in stereotactic neurosurgery. So, and his current appointment is Vice President of Moroccan Society of Neurosurgery from 2019, and he's a member of YNS form of WFNS and board member of Middle East Spine Society and chairman of French-speaking Young Neurosurgeon Committee. And today he will be speaking about volume target delineation of malignant brain tumors in gamma knife radiosurgery, time to change the paradigm. So I invite Dr. Fahad to speak about his lecture. Thank you.
Thank you, Dr. Ishu, for this kind introduction. I am honored to be with you today, and let me share my slides. Okay. So thank you all. Thank you, Thomas. Thank you, Professor Alberto and Professor Yoko Kato for this kind of invitation to join this webinar of the Fujita Health University Alumni Association for Neurosurgeon. It's just a great idea. I will try to apply that in our university too. And I think as alumni, it's very important for each university. I'm Fad Darqani. I am from Morocco, and my talk is about a question. It is time to change the paradigm about volume targeted delineation of malignant brain tumors in gamma knife radiosurgery. First, I want to congratulate Professor Yoko Kato for the WNS International Lifetime Recognition Award. She obviously deserves it. She's the real spirit of sharing science, of education, of innovation, and it's just amazing to hear Professor Kokato presenting or giving you advices even during coffee breaks or gala dinners. So I have the chance to meet Professor Kokato and at the WFNS Rabat Reference Center courses in Rabat and also in many other meetings around in Morocco, especially some courses, some workshops with different teams from the many universities from Japan, China, and also from Morocco. It was just great to meet her and to share some ideas and to have her encouragement to do more for neurosurgery. And she's just reflecting this citation or this quote: leadership is an action and not a position. And like we say, grains think like. I was introduced to Professor Yoko Kato by another great mind, my mentor, Professor Najil Abedi, and I have just the chance, I was lucky to meet both women in neurosurgery, sharing this spirit of equity for diversity, better education, better neurosurgery for all human beings around the world. Professor Najil Abedi, she's running for as a candidate for WFN's President-elect position, and I wish her a lot of luck. And I am sure that she's bringing a lot of creativity to our federation. We are working, me and Professor Najil Abedi, at the Department of Neurosurgery in Sheikh Zayed International Hospital. We are doing general surgery with specialization in different fields with our team, a lot of neurosurgeon and resident and intern, and we are also having an education program in neurosurgery at the New Abul Qasis International University, and we are working at the capital of Morocco, Rabat, and I wish you here in Rabat for the next in-person meeting once we have done with COVID-19, as it will be great to have you here and to share a lot of great moments in this beautiful city. We share also a lot of fascination to brain, to what we don't know about brain, his function and his abnormalities, and this fascination is shared by all neurosurgeons. Even Professor Ras Lexel, who inspired many neurosurgeons around the world by to offer the most accurate and the most adapted tool for brain surgery. And one of these tools is radiosurgery. He defined 70 years ago by the delivery of a single high dose of irradiation to the small and critically located intracranial volume through intact skull. Since this time, in 1969, the first prototype was created and first radiosurgical treatment was done and is still done, but with a lot of innovation and development, we have a more intuitive, more accurate, not accurate, intuitive, and more automated machines to offer this radiosurgical treatment. In the same time, MRI imaging has known a lot of developments. In 1952, Professor Felix Bloch and Edward Purcell had his Nobel Prize for about spectroscopy in the framework of nuclear magnetic resonance. And in 1966, Professor Ernest writes a paper about conception of MRI spectroscopy and deserved it for a Nobel Prize. And in 1917, Damadian had the first MRI. He believed on his letter on the potential of spectroscopy for non-destructive detection for tumor malignancy, what we are using today. And both Nobel Prize, Professor Mansfield and Lauterbur had this Nobel Prize for creating the first image in MRI. So it's a lot of developments that leads to a conventional morphological sequence that we use every time for radiosurgery, and also many other sequences like spectroscopy, tractography function, and other advanced sequences. And this, for example, will give us more information about this low-grade glioma. We can have this morphological description, but also the impact of this tumor on fiber tracts and also the metabolic behavior of a tumor. So in the WFN Laboratory Reference Center for Training of African Neurosurgeon, radiosurgery and MRI exists since a lot of years, and radiosurgery exists in Morocco since 2008 and is part of therapeutic arsenal for the management of brain tumor, functional and vascular pathology. And at this National Center of Rehabilitation and Neuroscience, we have the last generation of devices, the Lexel Gamma icon, using frames and frame-based radiosurgical treatments. And through a multidisciplinary approach, more than 2,000 cases were treated, including gliomas. So gliomas is a big deal in neurosurgery. 70% of brain tumors are high glioblastoma, and for high-grade gliomas, we propose surgery, radiotherapy, and chemotherapy. And we all know that with more radiation dose, with outcome, but more brain toxicity for few months of survival. We can use also this radiosurgery for the third-line therapeutical management of high-grade glioma, but with less outcome. We can see here on this Kaplan-Meier of a series of 54 cases in the WFNS Rabat Reference Center that we have less than than 20% survival at 2 years. So the way we still in the same situation with radio surgery or without radio surgery. But for low-grade glioma, we can offer 70% of non-recurrence at 5 years. So many questions to ask why we have this evolution. Even as we know that with radio surgery, we can offer higher radiation dose for lesion defined on treated T1 and flare with less toxicity, but it is the real target for gliomas. Some examples with this low-grade glioma, we had of brainstem. This child of 4 years old had first surgery, then radio surgery, and we have a good outcome with less volume of enhancement, less enhancement, no enhancement, and this cyst, I think 3 years after radio surgery with clinical outcome, and same tumor but different outcome. Here same planning, the surgeon targeted the morphological tumor and the enhancement, and just 8 months after there is a relapse and things goes bad for these patients. Another case of high-grade glioma, he's an aplastic glioma, and 1 year after radio surgery, same protocol of planning, we had an stabilization, if you can see that, and the clinical outcome is good, but just after 1 year. For a glioblastoma, this case of 6 years old man, he had surgery, chemotherapy first line, then relapse in second surgery, and another chemotherapy protocol, and we can do obviously another radiotherapy. So the team had proposed a radio surgery with a good outcome for enhancement for 14 months later, but 6 months after this control, we had a relapse, and even if we had less enhancement, no enhancement, we have a relapse, so we did not control the tumor. So what we have what we can do today is that with the all data that we had offered the MRI, we just use T1 and T2 and flare for gamma knife radiosurgery planning, and never spectroscopy. So even if we know that spectroscopy will offer a lot of information about metabolic behavior, and we can have study of all the volume of the tumor and surrounding tissue, normal tissue, obviously on morphologic, but we don't know if it is still, because we can have metabolic cartography with all details about the metabolic behavior of the tumor, and also for surrounding tumors. More tissue, I think, and even with this tumor that seems homogeneous on T1 with gadolinium, is still not non-heterogeneous in metabolic cartography using the choline NA index. And and this was proved in the in literature. This great paper of Dr. Sarah Nelson had pointed a good fact that MRI spectroscopy detects malignancy earlier than contrast enhancement on T1 sequences. We can see here in this case, this illustrative case, that on spectroscopy, what is in gray is malignancy, but we still have a normal appearance of the brain. And after radiotherapy, we have this recurrence that take more space, and even we start having necrosis and more. So spectroscopy can show earlier this tumor. And for glioblastoma as a infiltrating tumor, what we do with radiotherapy or radiosurgery, thus we had a radiation field including tumor and with the margin. And it seems that it is insufficient planning. That you can see here, that what is red is not it appear to be normal, but in spectroscopy is abnormal. So abnormality exists even before the morphological appearance of the tumor. And we know that recurrence often occur in the periphery of the irradiated tumor. And if we don't include this part in the radiotherapy, we just have a rapid extension to the periphery of the margin periphery of the tumor and relapse. So a lot of data that we don't use. And spectroscopy also allows the detection of malignant transformation of low-grade glioma compared with T1 with gadolinium, flare, diffusion, and perfusion. So we can, even before that appears, we have this transformation. So we ask ourselves, spectroscopy could be solution for better definition of target volume of radiosurgery treatment. What was reported by Pascual in his paper that there is a lot of difference between enhancement and spectroscopic volume, and it's not the same as T2 hypersonial volume. So we should be take attention and be aware about this fact that spectroscopy is indicative of metabolic abnormality in 80% of normal appearing, and the will occur in 90% of areas initially with metabolic abnormality alone without morphologic abnormality. And also, spectroscopy will allow to detect malignancy transformation of an initially benign real lesion during its evolution. So what we can conclude that metabolic volume is different from the radiosurgical volume. And the two fact that we can irradiate a non-tumoral volume, or we do not irradiate metabolic abnormality with a risk of recurrence in the periphery of this tumor in most cases. So uh, uh, we don't. So with this fact, we can even avoid to irradiate necrosis after radiation. And make a difference with tumor progression or recurrence. We can make difference between perilesional brain edema and tumor infiltration, and try to resolve some problems with impressive borders and tumor infiltration, and detect metabolic abnormality before morphological change and enhancement. And this will lead to maybe to exact definition of metabolically abnormal volume with a good irradiation, a good volume detection, less volume with high irradiation will lead to a better outcome in radiosurgery. And this will reduce the volume to be irradiated in a necessary way and increase the dose for areas with high tumor activity without increasing brain toxicity. And we all know that 96% of high-grade glioma cases had infiltrative metabolic pattern on spectroscopic MRI on perizinal edema, and even 11% have this infiltration in brain metastasis. And 63% of cases in an autopsy analysis of surrounding region of brain metastasis showed have a presence of infiltrative growth beyond the morphological border. So infiltrative exists in many tumors, in low-grade glioma, in high-grade glioma, in metastases, and we just still doing planning of non-infiltrative tumors for infiltrative tumors. This is a real problem today. And Shannon all noticed this a few years ago, and he tried to delineate the target volume for radiation by gadolinium surgery for glioma patients using without using this metabolic image cartography directly on the station. He just used two screens and just compared the information. And the metabolic mapping was performed according to Collin NR index greater than 1.6, and this allowed to decrease in the maximum diameter of target volume and decrease also the number of cases of post-radiosurgery cerebral edema. And why can do it? Because the integration of MRI spectroscopy on LXL gamma knife planning gamma plan, which is the planning program of gamma radiosurgery, is impossible. Spectroscopy is incompatible with gamma plan. So what we had for the hypothesis for research study is that it will be possible to integrate MRI spectroscopy on Lexel gamma plan. And this teamwork headed by Professor Abdeslam Khemlishi. We all know the Professor Abdeslam Khemlishi for offering all his service to better research and for approving medicine and neurosurgery, especially at the WFN Salvatore Reference Center. So the goals was, we have two goals. First, to create an algorithm to solve a compatibility problem, and the second was the development of an IT solution, an automated and productive integration during standard radiosurgical planning by Lexel Gamma plan. So at the National Center of Rehabilitation, we have the gamma nav, the MRI, and Lexel gamma plan, and all. And we start our study using this methodology, the reverse engineering. Why we choose the methodology? Because we have no access to the source code of Lexel gamma plan, the surgical treatment planning software. So we have to propose another solution. It's process of analyzing and giving IT solution to understand how it works and establish conclusion through this study, allowing to propose solution for certain shortcomings. This is the idea. The first is was to confirm the problem, and we obtain a metabolic mapping by MRI spectroscopy according to the Collin index higher than 2, and we attempt to upload metabolic mapping image to gamma plan, and the image was rejected by Lexel gamma plan inbox, even at the inbox. Never, we don't reach the planning software. So the next steps was compare, to modify, and to automate this process. So we compare what is compatible with what is not compatible with gamma plan. So compare multiplanar construction with MRI spectroscopy. And what we compare is DICOM, this the medical image that contains three main data: meta files, tags for general information, and tags for image. And it's what we need for this study, to study the image. And what we compare is multiplanar construction with spectroscopy using the DCM compare, a software dedicated to that, open source software of course. And here we define the main tags that can have a significant role in integration of an image on Lexel gamma plan. This is the main tags: row and column, photometric interpretation, sub-transfer syntax, bits stored and bits allocated. Sorry, I'm using some information, some technical information. I just learned that with a team, team of bio engineer. And this is what allow us to continue in this decisions program. So once we define these tags, we start modifying or editing this metadata using the GDICOM software, also open source. And the first one is the matrix pixel. The matrix pixel defines the length and the height of an image. This is the pixel, and the pixel defines the resolution of an image with column and row. And what we noticed on multiplanar construction, that the image should be matrix square to be accepted by gamma plan. So what we have done, just we give the number of the columns to the rows, and the image was so we had the shortcut. What is that was create a square matrix image empty and overlay with the DICOM image with fusion of both centers of both images. And here we resolve the problem without modifying the contents of the data or the image. The second one is the slice tags, the spacing between slices. So, and the deviation from the visualization model was too big, and the series cannot be accepted. So, what we have done is that we conclude after several changes, we conclude that the space between slices should be less than 1.5 millimeters to be accepted. And this was the second point. The third point is patient position and orientation of the patient. The series of spectroscopy contain image with different orientation because it's just volume study and not slices one after one. So what we have done is that we give coordinates in spaces according to the multiplanar construction that we used for spectroscopy, and then using GDICOM we give this information of transition between the different images to create 3D volume, and this 3D volume should contain at least three slices. So every series of metabolic cartography should have three slices. This means three volume studies, and this will lead to be accepted in gamma plan. And the last tag was photometric image. We have three possible types of color code in each pixel. So we have 8 bytes, 16 bytes, and RGB, red, green, and blue blue code is 24 bytes. L'Excel Gamma Plan accepts grayscale image only. So we have the choice between 8 bytes and 16 bytes, and we chose monochrome 2 for this photometric study. How we do it? We just transform this image, colored image, to a grayscale image, and this is the result. We can include the metabolic cartography on l'Excel Gamma Plan. And we establish a protocol with 6 criteria. Space between slices should be less than 1.5 millimeters. We should have successive slices with coordination, matrix square for images, 3 DICOM slices per series at least, same values of rotation, scale image to include this. And to do this, we need to do it. If we want to do it manually, we can do it will take a lot of time. We can do a lot of mistakes, and we can even destroy the image, and this against the precision, which is the aim of radiosurgery and neurosurgery. So the third step was, or the first step was to automate this protocol, and we use Python with this open source programming software to create an IT solution to make this metabolic mapping integration work as a reproducible and fast producible without risk of error, and the software was installed on computer running on Microsoft Windows operating system. And this is just an example of the program. And the result was the GP adapting solution with main menu, with display screen, with list of image, and you can upload your images. You have the list, you can visualize them, transform them, and then once you have this, you do this this modification, and you can upload these images on CD-ROM or inject the images on packs. And then you can upload them on the Gamma Plan inbox. And to have again this color code as color code, we use option on Gamma Plan. We use this option of rainbow image, and we have this algorithm that make a relation between spectroscopy and rainbow image, and then we offer this the three plannings, the three images, morphological, T1, T2, and also metabolic cartography for the radiosurgeon to make a 3D planning and to make this radiosurgical treatment adapted to the morphology and also to metabolic behavior of a tumor. And this will take only 5 minutes longer than usual planning, additional to 10 minutes on MRI for multivoxel spectroscopy study. And you can find all this protocol on paper that we have published on journal with the 5 protocol with 3 steps. Step 1, MRI acquisition. Step 2, converting station to compatible ICOM images for Gamma Plan. And step 3, which is uploading a compatible MRI to Gamma Plan and planning. And here we are offering a modest solution. It is the first software described that allows this integration with a predictable procedure adapted to daily clinical practice. We We respect the integrity of medical image and without modification of the data, and we respect the open source and the ethics and the law, and all softwares used are open source, and we can apply this same algorithm to integrate any DICOM tip medical images on gamma plan station. Functional MRI will be integrated on the next version, and and this is the starting of the program for functional MRI. And like for an example, this theoretical application to a case of low-grade glioma. This is right low-grade glioma, brainstem low-grade glioma, and diencephalic. The patient has a planning according to classical protocol using T1 and T2, and T1 with gadolinium, multiplanar reconstruction for a follow-up for 2 years. At the beginning of this planning, we had MRI spectroscopy with metabolic cartography that we don't use to make the plan by radiosurgeon. And here, at 2 years follows up, we have a good outcome. Favorable, yes, but in homogeneous response. The tumor, we have tumor residue, and the tumor residue at 2 years is located in the hot spot areas corresponding to the highest scoring NR index. So many questions should be asked here. The hypothesis of dose distribution correlated to the metabolic profile of each pathological zone is to be evoked. Different doses could be done for metabolically different volumes. Why not? Or even should we just irradiate what is metabolically abnormal targets, and only a prospective study to be will give an answer to this to these questions. We assert the hypothesis metabolic imaging can be integrated into radiosurgical planning by Lexa gamma plan, and it's just the beginning. When it comes to the human brain, no significant advances is too much. The development of new future in neurosurgery is needed, and just another tool for neurosurgeon to overcome all difficulties with gliomas, with metastases, and with all affiliative tumors. We start studying this metabolic planning mapping the treatment of brain tumors, and maybe we can reach the goal of having new data with new planning protocols in tumor and functional radiosurgery. The software will be available to radiosurgeon in open source, and the contribution of all of us is needed to reach to this research work for development of new IT solution in radiosurgery, extending its clinical application. We started a partnership with Harvard Medical School, and I will thank Professor Alexandra Golby for her help to start this study. And all teams are welcome if you want to join us for multi-center study. And also we need future collaboration with neuroimaging work group and bioengineering to develop more accurate and adapted tools for brain problems. So if you want to join this study, you can just contact me on this email. And thank you very much. And this work is dedicated to the memory of my colleague, my friend, late Professor Suad Bakhti. Rest in peace, Suad. Thank you.
Thank you, Dr. Fahd. It was very nice lecture, very informative, and it was very new. And the total information it was very cumbersome, and it's a good step for the future because the difficult locations of the tumor, like in thalamus and in periventricular region, and they are mostly not good for surgical resection. And this new research project, it will change the uh, I think the progression free survival of these type of patients, because we can achieve good results with this research. So
Thank you.
now I
Thank
would
you.
like to invite our attending and guests to ask questions. So please ask questions if you have any.
Can I have question?
Sure.
Can I ask your
Yes.
question, Dr. Hassan?
Yes, please
Thank
go.
you. Yeah, this is a question from Thailand. So I have two questions. For application for the current practice, the MR spec of MR spec is for the handle of this imaging is depend on the neuroradiologist. Do you recommend to another protocol of the imaging if some hospital they don't have neuroradiologist to interpret about the MR spec? Do you have any recommend for another protocol such as post-gadolinium T1 with thin slide? It can measure about the volume for accuracy before to perform the gamma knife. Do you understand? This is the first question. And the second question, as you know, the high-grade glioma, they have the high chance for seeding along the leptomeningeal seeding or CSF spreading. Once we perform the gamma knife for local like radiation, how about the occult metastasis from the CSF spreading? Do you have any regimen or any treatment protocol to treat it like this? Thank you.
Thank you very much for these relevant questions. So, without a good neuroradiologist, you can't do good MRI imaging that's leads to good precision and to have all this data. What I can say that at the WFNS Arbats Reference Center, we have a reference neuroimaging guy. It's Professor Jiden, who is just light of neuroimaging in our country, and he tried to develop more sequences on his machine. He never stops, and he was a great help for us as a research team to have this image and to develop this. To know that we to apply this. To develop this software, you need to try to make a lot of tries, and it's depend on an MRI dedicated to clinical practice. So you need he should give us more time for research on a machine that's used for what you call it, MRI for everyday MRI for a lot of patients. So he was patient, he was creative, and we can do that. If can we replace this with other imaging? I don't know. I'm not a radiologist, okay, but what I understand that even with MRI we need time to reach this high level of accuracy, of distortion avoidance. Distortion is a real problem for stereotaxic and functional neurosurgery, and also for neuroimaging. So CT is always used for gamma knife radiosurgery for accuracy, but here what we add that we have more accuracy for public behavior of a tumor, so of tumor and the surrounding tissue, that we can irradiate even if also if the volume is accepted by a radiosurgeon. And here with the icon, I think we have this possibility to have staged irradiation. I don't know if we can use it for high-grade glioma, I'm sure, but for low-grade glioma, maybe yes. It's new concepts, and we're still waiting the results of our patients, and also for the papers for other teams. Radiosurgery for gliomas is not used as a usual mode. It's just for selected patients, and I agree that for high-grade glioma we just have a local control. We try We don't have this local control. We try to have this local control. We are far away from having this local control, and the decision is taken in a multidisciplinary team that here in the center we have a meeting every Thursday with neurologist, neurosurgeon, and radiosurgeon, oncologist, radiotherapist, and physician, biophysician, to make to have this decision for every patient. It's not always possible, and if we use radiosurgery is in multidisciplinary protocol for with another protocol for chemotherapy. So do we use intratracheal chemotherapy? No. No, and just we have the second line chemotherapy, and then if there is progression for high-grade glioma, it depends on the APA. If the patient is in good health, we can propose another thing. But if we think that he will not support additional, or will not offer him a good outcome with good outcome with a good life during the next month. So we just need to stop, and this is what is difficult in neurosurgery, to know where we should stop.
Thank you very much.
Did I answer to your questions?
Yeah, sure, of course. Thank you.
Yeah, thank you so much.
We are joined by Professor Yoko Kato here. Welcome, madam. Can you hear us?
Hi, how are you? I'm in the car. I'm so sorry.
Hi, Professor.
Hi, how are you?
Hi.
Thank you very much, Pat.
Thank you so much.
Thank you for everything. Yes, thank you for everything what you have done for the WebS course, everything. So many web education course. It was perfect.
So you are driving.
We just following. We're just following your steps.
Thank you so much.
Thank you.
Can I have one question for you? Is it okay?
Please.
So what about the recurrence ratio with your methodology of the high-grade glioma? Can you tell us, please?
Yes, so I can't answer to this question because we just have theoretical creation of this the software. We will start a clinical study, okay, in the next few months. I think in the beginning of 2022, and here we can have this the real question. Thank you for this question, Professor Kato. Can we change this recurrence? Can we have a local control of the tumor? If we can do it, we can adopt this protocol. If we can't, we don't need to spend all these financial resources, all this time for things. So we need to this study to answer to this question, and also this software is just of the puzzle. We need to develop other. We need to develop other solutions like chemotherapy, like immunotherapy, and if we add all these pieces in the same puzzle, maybe we can reach our goals as neurosurgeons, is to control this high-grade glioma. That's this nightmare.
Thank you.
Thank
so you are one of the representative of African YNS. Please join us more and more. Thank you so much. Wonderful talk. Thank you.
Thank you so much, Professor. Thank you. And congratulations, Professor Yuko Kato, for your word. the WMS award. You really deserve it, and we are really honored to have you as a member of many neurosurgeon in Africa and Asia and around the world. Thank you so much for what you are sharing with us as information, as education, and as a philosophy in neurosurgery. Thank you so much.
Thank you both of your support. Thank you so much.
Thank you so much.
So much. Yes.
Thank you, Professor Kato. We will, I think, because of the time, we will continue to our second speaker. Our second speaker is Dr. Anna Shulgina with the title of Association between Bypass Function, Neoangiogenesis and Clinical Outcomes after Combined Revascularization in Patients with MoyaMoya Disease. I would like to read a short CV of Dr. Anna. So Dr. Anna Shulgina is working in Burdenko National Scientific and Practical Center for Neurosurgery in Moscow, Russia. Dr. Shulgina is an MD and PhD neurosurgeon and a scientific researcher and scientific editor of the Burdenko's Journal of Neurosurgery. Dr. Anna has research interests in vascular neurosurgery, surgical revascularization, bypass surgery, MoyaMoya disease, and cerebral ischemia. She had more than 30 publications and more than 20 oral presentations. So, Dr. Anna, please have your presentations. Thank you.
Good morning, dear colleagues. Thank you very much, Dr. Thomas. Thank you, Professor Kata, for this opportunity. As you know, I work in a National Medical Research Center for Neurosurgery in Moscow, and I want to have a few words about this center. It was established in 1932 by academician Nikolai Burdenko, who was the founder of Russian neurosurgery, and now it is the largest neurosurgical hospital in Russia. So we treat all patients from all over the country with all kinds of neurosurgical pathology. We have 10 neurosurgical departments and perform about 60 surgeries daily. We have 20 ORs with special equipment, big ICU department, radiological department. For 40 years, our director was academician Professor Alexander Konovalov, who is the great Russian neurosurgeon. And since 2019, the director of our center is Professor Dmitry Usachov, who is my scientific supervisor. He founded the group of vascular reconstructive surgery where I work. We deal with atherosclerotic lesions of brachycephalic arteries, chronic ischemia of the brain, MoyaMoya disease, neck tumors, and the other pathology. Our operations include especially carotid endarterectomy and reconstructive surgery of all parts of extracranial and intracranial parts of the main arteries of the brain. We will be glad to see all of you in Moscow in our center. In last year, I finished my PhD program and defended a thesis on theme of MoyaMoya disease. We had a big scientific work on this disease, and today I want to present you the results of the research about special theme, the association between bypass function, neoangiogenesis, and clinical outcomes after revascularization in patients with MoyaMoya disease. As you know, MoyaMoya disease is a specific chronic cerebrovascular pathology with a complex pathophysiology and its own specific features. The disease has a steadily progressive course. The natural course of the disease is associated with a poor prognosis, with an extremely high frequency of primary and recurrent ischemic strokes and hemorrhages. The effectiveness of surgical revascularization in both ischemic and hemorrhagic forms of the disease has been proved by world community, which made it possible to include surgical revascularization as a generally accepted method in recommendations with a high level of evidence. In surgical treatment, two approaches are traditionally used, direct and indirect revascularization with the variety of their options, and current trends are converged to a combination of these techniques, combined revascularization. However, there is still a big question: what factors affect the effectiveness of direct and indirect components, and what is the most justified variant of the revascularization? So to identify the possible factors, we analyzed 80 patients with MoyaMoya disease who were operated in our center. The total number of the operation was 134 operations. All patients were examined according to a single protocol to evaluate clinical, morphological, vascular, and perfusion features that could probably affect the result of revascularization. We divided all patients into 3 groups, depending on the type of surgery. So we had a main group of combined revascularization and 2 control groups with direct and indirect revascularization. The results of the early postoperative period were significantly different between the main and control groups. Good results of combined revascularization were observed in 77% of cases, which is slightly worse than the result of the direct group, where the number of good results was 94, but much better than the results of indirect group, where there was the highest number of complications. However, in the long-term postoperative period, the combined revascularization showed the best results, which was manifested by an improvement in vocal and cerebral neurological symptoms in 73 and 69% of cases, in contrast with the direct group, where the improvement in neurological symptoms occurred only in 33% of patients. These results were attributed to a significant improvement in cerebral blood flow. In the parameters of cerebral perfusion, all patients showed a significant improvement in CBF in the territory of MCA and ACA, which led to shift the degrees of perfusion deficit towards more compensated forms. The best perfusion results were observed in the combined revascularization group, where there was increased CBF in a larger area of the brain. This significantly exceeded the results of direct revascularization, after which more often there was only a local improvement in CBF. The main reason for this was the better degree of revascularization during combined operations. The best results of the direct component were observed in the combined group, where the best degree of functioning of bypass with the hypertrophy of STA was observed in 70% compared to 28% in the direct group. Analysis of factors of the effectiveness of direct anastomosis revealed that the diameter of donor and acceptor branch and the imposition of double anastomosis significantly affect the efficiency of the direct revascularization. And the best results were observed with the larger diameter of the acceptor and donor arteries. During angiographic assessment of indirect revascularization, as was expected, the effectiveness of indirect components depended on the time of follow-up period, which was significantly longer in patients from the indirect group. However, in the combined group, there were similar results that were achieved earlier due to the use of a larger number of tissues. Analysis of the factors of the effectiveness of indirect revascularization revealed that the younger age of patients, the EV sign on MRI, dilatation of M4 branches of MCA, the presence of leptomeningeal and transdural collaterals, and the use of a larger number of indirect components had a positive effect on the development of synangiosis. Evaluation of the general angiographic result of revascularization revealed a significant predominance of large volumes of vascularization in combined group compared to the direct one, which was due to the development of indirect components. At the same time, there was a complementary influence of direct and indirect components in combined revascularization on the provision of good angiographic and perfusion results. The best results were observed in cases of the joint influence of all components. However, if one component was ineffective, the other played a protective role in ensuring a good overall result of revascularization. And a similar picture was obtained for perfusion results. The conclusions of our research are the factors of efficacy of direct bypasses are a larger diameter of the acceptor and donor branches and imposition of double anastomosis. Factors of efficacy of indirect synangiosis are the younger age of patients, the EV sign on MRI, dilatation of M4 branches of MCA, the presence of transdural and leptomeningeal collaterals, and the use of a larger number of indirect components. And the best results of revascularization are achieved with a combined influence of direct and indirect components. So the preferred surgical method for patients with MoyaMoya disease are combined revascularization that in the long-term postoperative period provides better clinical results compared to direct and indirect revascularization due to a greater restoration of cerebral blood flow. Indeed, in our practice, our surgical approach was evolved from the creation of one component anastomosis and synangiosis to the use of the maximum possible number of tissues. The dura mater, both branches of STA, temporal muscle, and additional bore holes. So all these components provide a great advantage of the clinical improvement after combined revascularization in long-term follow-up period compared to direct and indirect operations, as you see on diagram. Here is an example of effective combined revascularization with complete restoration of blood flow in the whole hemisphere of the brain. Due to bypasses and neovascularization from indirect components. And here is another example of effective combined revascularization. In conclusion, I would like to say that surgical treatment and work on the study of various aspects of MoyaMoya disease in our center has been conducted since 2008. And I also would like to express my great gratitude to the Professor Kata and Professor Mao and Shubin from Shanghai, who did great help and assistance to us in learning and mastering skills in the treatment of MoyaMoya disease. Huashan Hospital, where I had an observationship program. We hope that the knowledge of our research will make it possible to more rationally and efficiently use the components of combined revascularization and to improve the effect of the operation. Thank you.
Thank you, Dr. Anna. Now we would like to open question session. Are there any questions from the panelists?
May I?
Yes, please, Dr. Ishu.
It's not question. The presentation was very nice, and thank you for the presentation. And based on the findings, now we can say that the bypass and indirect, both they are better for long-term follow-up. The idea was why simply bypass cannot achieve the same result as combined, because bypass is providing the supply from external carotid system. Still, it is not giving result up to combined approach.
Yeah, thank you very much. This was one of the aims of our research, is to compare the role of each of the component in providing the result. So we found that only bypass surgery do not provide such results because of the small area of revascularization, only local restoration of blood flow. But the indirect components that we perform to revascularize the areas of the brain where bypass cannot provide the restoration. This is the territory of ACA territory or PCA territory. So these components provide more large territory. And that's why the combined revascularization group has better results in the long-term period, because the bypass provides short-term improvement, but the long-term improvement provides by mostly indirect components.
Thank you.
Are there
Maybe
any?
I can.
Yeah,
Can I
please,
ask a
Dr.
question?
Fad. Please, Dr. Fad.
Thank you, Dr. Anna, for for sharing this experience, and it's just nice work. I just ask, here in Morocco, we don't have a lot of cases of MoyaMoya. Just I don't. It's not. Last year, I think we have seen just one or two cases this last year. So we are not so familiar with the vascularization, bypass surgery, and all of that. So before going to do this great research work, maybe for sure you have a program for revascularization for residents and for young neurosurgeon. Can you describe it, please?
Describe the program, you mean?
Yes, yeah, program. How young neurosurgeon have this ability to do vasculation and bypass surgery.
Yes, thank you. Actually, bypass surgery is performing in our center for a long time, but we do not have experience with MoyaMoya patients, because these patients is a specific group that, and we cannot apply standard protocols for them. So we had just indirect or direct surgery for them. But when I started to study this theme, I revealed that these patients need the other approach. So I traveled in Japan, in China, in Korea, and observed the methods of the revascularization in these countries, because they have a lot of cases. So I knew that that these patients need a combined revascularization. And then we started to apply this approach in our center and collecting the results. And we see that the results are much better than we had before.
Thank you.
Thank you, Dr. Anna. I think your research is adding a body of knowledge for a reference that combined technique is more superior than other technique in MoyaMoya. I have a question, probably not that related with your research. Actually, I haven't got any cases of MoyaMoya disease in my country or in my practice, but I just have a thought or a thinking that have you got any or a case for secondary surgery or secondary neurosurgery for a case that been operated for MoyaMoya disease for other pathologies, like probably after in the older ages got stroke or something that for second surgery. So have you got any case for that? And is there any
Yes, thank you for your question. We usually perform bypass surgery for patients after ischemic strokes with occlusion of ICA or MCA. So it's our standard practice, but these patients do not need indirect components because they will be ineffective in them. So we just apply one or two bypasses for them.
I'm sorry. My question is let me make it more clearly. If usually MoyaMoya disease came with or come with adolescent or juvenile age. So
Okay.
after they got a surgery for a bypass surgery, direct and indirect, like combined approach, and after they age and have probably stroke in the future and needed a surgery, is there any special consideration about that the patient got a bypass surgery or a history of bypass surgery, probably like that? Is there any special technique or considerations?
Yes, thank you. I see now what you mean. Yes, we had some cases when previously performed surgery do not restore so much blood flow, so we need to do the second or third or fourth operations in them. But actually, when you previously used STA branch, so we only have an opportunity to perform indirect revascularization in the area of ACA or PCA. It depends on the territory that is suffering from a low blood flow. So we have some cases when we have to do more operations than two. Actually, if you apply wide technique of wide combined revascularization, patients do not need some more operations because you see the examples that this technique provides a great restoration of blood flow in the whole hemisphere. So we just observe them and see that in many years they have a stable picture of perfusion and clinical picture.
Okay, thank you, Dr. Anna. For my co-host, is there any questions or comments, Dr. Ishu?
Thank you. So now, if there are no questions, we can come.
I have one question for Anna.
Yeah, Prophet.
So
Yes,
Anna,
Prophet.
thank you very much.
Thank you.
So very nice to see you again.
Nice to see you.
Nice. Thank you. Thank you. So you mentioned about the angiogenesis because the MoyaMoya disease need more blood congenitally. So I think in a future treatment, except for bypass, any the paper or someone said about some additional drug assistance.
Thank you, Professor Kata. Glad to see you again. Usually we use aspirin for these patients, but unfortunately there is no medications that could stop the progression of the disease. We just use a symptomatic therapy like aspirin or anticonvulsants or some others, but no treatment, but no medical treatment for the progression.
So can you prevent the future, for example, in adult case, the prevent to develop the micro aneurysm, which will be the cause of the hemorrhage in adults?
Yes, I know that they can have aneurysms, but in our practice, we didn't see such cases.
Okay, thank you.
I have one comment. This is based on Professor, your question. Uh, I had one case presentation. I got one child that was around 8 year old, and he was proven case of MoyaMoya disease, and I advised him bypass surgery, but the attendants, the parents, they refused, and then the child was repeatedly having severe headache, and because that child was not investigated proper, and then one day he had very severe headache with vomiting, and then that caused death of that child. And now I got that was because of the mycotic aneurysm that got undiagnosed in that case. So this must be looked, the mycotic aneurysms, if the moya cases, they are presenting with severe headache, and now I can retrospectively correlate with that child that he must be having this bleed from the mycotic aneurysm that was missed, because we are not regularly getting the mycotic aneurysm in moya. It's rare, but it is there. We should look for it. So this
Yeah.
is for you, Dr. Anna. Like you can in future, you can specifically show special interest in cases who are having severe headache.
Oh, thank you. Okay.
Yeah. Can I have some comments for
Yes.
Dr. Issue? As the principle of hemodynamic stress, due to, as you know, the MoyaMoya disease, they have like a genesis or occlusion about the ICA terminus. So the blood pressure have like a shear stress around the circle of release, especially or the PCOM artery or basilar artery. It's a backflow to basilar top.
Yes.
So the aneurysm can originate or can occur for the de novo at the around that system. So once you have the just case of MoyaMoya disease, you
Yes.
should look for associated aneurysm because the incidence around 20%. This is very very important point. We should look at that point.
Yes.
So we can treat. But for combined revascularization can decrease about the hemodynamic stress. So aneurysm maybe in the future it cannot occur allow the circle of release. Can I ask Anna for another one question? In the current practice, almost of the patient they don't have the full criteria for MoyaMoya disease. They have like a MoyaMoya-like disease, such as for after vasculitis or after infection or after stroke or after atherosclerotic disease. And the M1, they have developed about the basal cholesterol. It's really look like MoyaMoya disease. So in this point, do you agree to continue the treatment strategy like a MoyaMoya disease for direct revascularization and indirect revascularization, or you still do anyway? Thank you.
Thank you for this question. Yes, actually, this is MoyaMoya syndrome. But the condition that is like MoyaMoya, but it has underlying disease, just like vasculitis or rheumatologic problems or vasculitis or thrombophilia. Yes, if we see such a patient, we refer them to the other doctors that diagnose this underlying disease, and if it is necessary, they prescribe medical therapy for them. But in cases when we cannot reveal the reason for this condition, we do revascularization, we do bypasses. In any cases, and the use of combined revascularization, yes, we can use and indirect components too, but the effectiveness of them is lower than in patients with MoyaMoya disease.
Yeah, I agree with you, because in my practice, I also do like that. Thank you very much.
Thank you very much. And about the aneurysms, we perform DSA in each patient before the surgery. So we are looking for all the pathologies of all the vessels. So we do not, we can see these aneurysms if they are. But it is actually rare, because I told with Professor Shubin, who had the greatest experience in the world in the MoyaMoya disease, and he saw only a few cases of aneurysms. But he say, actually, if there are an aneurysms, you should perform bypass surgery, so the pressure will be lower on aneurysms and they can regress.
Thank you.
Thank you.
Thank
So-
you, Dr. Anna and Dr. Itichai.
Okay,
So,
so yeah.
any comments or questions?
Dr. Liu, any question to her?
Yes, probably Anna, I wish to ask for you, since you have identified the predictor of effective and ineffective outcome. Do you plan to do any scoring system to predict the outcome of certain patient? So at least in your pre-operative, especially that you have done angio, for example, for the size of the STA, for example, where you can predict the outcome. So are you going to do that in the future? Thank you.
Oh, thank you very much. Yes, we actually had a scoring system for the predicting complications in these patients. This was not in my presentation, but we did such a gradation, and we had a group of patients with high risk of ischemic complications. But it is a very good idea, and I think we should do this in the future for the good outcomes of revascularization. Thank you.
Thank you.
Thank you. May I kindly add to that point that when the two great speakers were Professor Jacques Morcos and Professor Fadi Charbel came to the ACNS webinars to give their and had their lecture, in both stressed upon the points that you should not be disappointed by the preoperative assessment of the caliber of the STA, because once you dissect and free of them of the adventitia, they enlarge. So that was one good point by Professor Fadi Charbel and Professor Jacques Morcos. So I would like to make that point that even if you have a scoring system, the net effective size of the STA would be changing after the final dissection and when you are readying the graft for bypass. Thank you very much.
Thank you. Yes, thank you. Maybe this is so, but the preoperative evaluation of the STA is important too, I think, because even if it will enlarge during the dissection, it has some limits. If you see very small hypoplastic STA branch on preoperative angiographic study, it will not increase in many times during dissection.
I would recommend you to watch that lecture by Professor Fadi Charbel, where he shows preoperative that the flow in the STA branch is dependent upon the demand. it may not be there pre-operatively. Only after post-operative phase, when you assess it for the flow, you will find that the flow is actually much more beyond what is anticipated. That is what
Yes, thank you very much. But also it is dependent on the acceptor power of the MCA branch. If you have poor MCA branch territory, even a good donor vessel could not provide you much flow in the bypass.
Thank you very much.
So now I think it's time to close our webinar. And Professor, do you want to say any closing remarks?
No, it's fine.
Okay.
And both speakers were excellent, I think.
Yes.
So yeah, we should expect that from the next time again.
Yeah, and the topics were new and they were great.
Yeah.
So, see.
Well, thank you so much.
Thank you so much, madam. Thank you so much.
Thank you and bye-bye.
Thank you. Bye-bye.
Bye.
Thank you.
Thank you. Thanks so much, Anna.
Thank
To
you,
be
Professor
healthy.
Kato.
Yes, please stay safe. Thank you.